Halo. Assalamualaikum. Hello. Assalamualaikum. You guys here?
Yes, Waalaikumsalam.
Right. So it's 8:30. Shall we start our class now? No.
Yes, doctor. You can start.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Very good morning. How are you, students? On a Monday morning? Sihat ke? Korang dekat college kan?
Betul kat college.
Buat apa? Weekend? Pergi berjalan eh?
Pusing
Ha?
sini je. Pusing-pusing dalam ni je. Berjalan pun ya juga.
Okay, that's good. So as long as you take small breaks, that's good. A break is always needed in the midst of your busy schedule to refresh yourself. Okay, so today we'll be learning about atrial fibrillation. Okay, I've actually put the slides already dekat Google Classroom, so I hope you can use it as a guide lah throughout my lecture. Okay, this is a big topic and it's an important topic for you guys to pay attention lah. Okay, so please please pay attention. Okay, those yang tak dapat nak join, as usual lah, they can watch the recorded session. Okay, so basically the main reference that I use for this topic is the ESC guideline, okay, as well as your pharmacotherapy book. You all ada access ke kepada pharmacotherapy book tu from the library? No? Ada? You all semua dah ada ke buku tu? It's very important for you guys to have that book. So that further readings can be done from the book.
Ibu.
Ibu tak kisahlah, ibu ke, the actual book ke, it doesn't matter. The PDF ke. Okay. So library bagi loan ke macam mana? No? So mana-mana yang tak dapat tu make sure you all try to get it lah. Okay? Borrow ke apa ke. Alright. So this is the course outline. Okay, at the end of this course, you should be able to to know the definition, okay, pathophysiology, risk factors, diagnosis and detection, clinical presentation of AF, ERA symptom scale, how you want to manage AF, and some monitoring parameters. Okay, so before we start, let's look at some of the definition of atrial fibrillation. Okay, so atrial fibrillation, it's a supraventricular tachyarrhythmia with an uncoordinated atrial activation and consequently cause ineffective atrial contraction. So tadi dalam my pre-class activities, I've asked you to look at some of the videos for atrial fibrillation. So did you guys manage to watch them? Because I think with 1 hour's lecture, we won't have enough time to go through everything. Y'all dapat tak? Tengok videos. The one that I posted, because this time around your classmates tak ada yang post anything regarding to AF. So I had to find some videos from the YouTube lah. Okay, the pathophysiology. There's one video, the last video was on patient's perspective with having AF. So mana-mana yang tak tengok lagi tu, you can have a look lah. Okay, like I said, the British Heart Foundation is a good website for you to find resources, okay, with regards to many heart diseases, including atrial fibrillation. Okay, so I think it's BHF, British Heart Foundation ni dia it's easy to understand because they use a lot of layman term. So macam after, probably before reading your pharmacotherapy book, kalau you nak have a basic idea about whatever disease, you can have a look at the British Heart Foundation first, and then you dive into your pharmacotherapy book, right? So so as you can see, the keyword here in atrial fibrillation, okay, there is an uncoordinated atrial electrical activation. Okay, kalau you tengok most of AF videos pun, that's what they show. Okay, due to this uncoordinated atrial activation, there is an ineffective atrial contraction. Okay, so AF ni is a disease of the heart. It's an electrical disease of the heart. Okay, so that's the layman term lah. It's not as common as your other heart disease. Okay, like your heart attack, okay, your heart failure, hypertension. It's not that common. And hence that's why we need to increase awareness among patients who have AF. Okay, so it's a problem of the heart where the heart cannot beat properly. Okay, so that's what AF is. So you need to have a confirmation from your ECG, okay, to diagnose AF. So AF occurs when there is an irregularly irregular RR intervals. There is an absence of a distinct repeating P waves, and there is irregular atrial activation. I will show you an example of an ECG of a patient with AF. Okay. So there is a currently used term called clinical AF, symptomatic or asymptomatic AF that is documented by a surface ECG, and the minimum duration of an ECG tracing of AF required to establish the diagnosis of clinical AF is at least 30 seconds or the entire 12-lead ECG. So when you do an ECG, so when patients present to the ED with the complaint of AF, with the complaint of palpitation, okay, you have to do an ECG and to look whether the palpitation is just a normal palpitation or whether the patient has AF or not. Okay, so macam mana nak tahu patient has AF? Macam ni lah, dia tengok kat ECG, there's an irregular RR interval, no P wave, okay. So this abnormalities have to happen at least 30 seconds at the ECG punya tracing tu. Okay, these are some of the definition, you can have a look. Right. So okay, so what about the epidemiology? Okay, among the other types of arrhythmia, AF is the most common type of irregular heartbeat, and hence that's why I'm focusing more on atrial fibrillation. There are other types of arrhythmia like your ventricular fibrillation. So if you want to have if you want to know about those, please go to your pharmacotherapy book and have a read. But as far as I'm concerned, I'll be focusing more on atrial fibrillation. Okay, so it's a major global health burden worldwide. Okay, in the US and in European countries, about 1 in every 4 middle-aged adults develop AF. Now, dekat Malaysia, jarang kita dengar patient ada this problem. Betul tak? Guys, betul tak? Like when we speak to people, to the lay person, we rarely hear them say that they have this irregular heartbeat problem. Betul? Bila I bagi you the assignment lah yang untuk buat video tu pun, I noticed that there's none from 183 of you showing a video of AF showing that this problem is not that common as compared to your other heart disease like STEMI, non-STEMI, hypertension, heart failure. I think because the problem in Malaysia, because we are not aware of it and there is less detection method. Whereas in the European countries and in the US, awareness about this disease is wide, and hence they are able to detect patient, because you see about 1 in every 4 middle-aged adults develop AF. Now, why is it important for you to know, for people to know that they might have AF or not? Because AF is associated with 5 times risk of stroke, okay? Increased risk of death and development of heart failure, and greater risk of hospital admission. Because maybe we people from Asian countries, we do not know about this. Even though they might think that, oh, it's just an irregular heartbeat, what's wrong with that? You know, people might be anxious and have a high heartbeat, especially when when we want to do something very stressful, we want to do public speaking. Of course, our heart rate goes high, isn't it? So, I'm thinking that people might think this is a normal thing, but if you are an elderly, you have hypertension, and you notice that your heart rate is being very irregular in many times, then that's what do you call a sign that you need to get yourself properly checked. Yeah, because if you don't, you are at risk of getting AF. And what's scary is that when you have AF, you have 5 times higher risk of getting a stroke. That's what we don't want, because when you have a stroke, especially due to AF, it is more worse, okay, than your normal ischemic stroke, okay, and it results in a worse outcome. See, example like increased risk of death. Patients can get heart failure, and there is a greater risk of hospital admission. Okay, in Malaysia, the prevalence of AF is about 0.5%. Like I said, it's not that many as compared to the other parts of the world. As you can see here, most of the AF is mainly detected in the Western countries, and in the US, as you can see, the one in red here. Malaysia, we are here. We are the last, the second last of detecting AF, because I said probably because we are not aware of it and we are not looking hard enough to find patients with AF. Okay, but globally about 44 million people has AF. This was done in 2016. Now, like I said, it's the lifetime risk of AF is about 1 in 3 individuals, okay? And it is more common in males, unfortunately, guys. And this is not good for you, not a good, unfortunately, not a good news for you, okay? And it is projected to increase among patients who are elderly, as you can see here in the green graph here. Okay, elderlies are at higher risk of getting AF. Okay, you see 65 years and above as well. Okay, and the lifetime risk of AF increases with the increasing risk burden, meaning the more risk burden that you have, the higher risk of you getting AF. Risk burden means like smoking, okay, alcohol consumption, high body mass index, high BP, diabetes mellitus, and a history of myocardial infarction or heart failure. So if you have more of these, then the risk of you getting AF is high. Okay, so I did this review when I was doing my PhD, and as you can see here, Malaysia, the prevalence of AF in Malaysia is about 0.5% compared to other parts of the world. Like in Australia, we have about 5% of the population has AF. Okay, like I said, probably due to lower detection method, lower awareness among us, and hence that's why less chances of us finding people with AF. Now, the pathophysiology of AF, like I said, I've asked you to look at the videos, but in essence, what happens in AF? This is your normal heartbeat, okay, where your your electrical conduction is being controlled by the SA node over here. Okay, what happens in AF is that the upper chambers and the lower chambers, they are not coordinated. There is a lot of firing, electrical firing at the upper chamber, at the atria, causing a destructive pattern of the electrical conduction. So when there is a kat sini ada firing, kat sini ada firing, so the ventricles cannot respond properly, and this causing your heart to beat either too slowly, too quickly, or irregular. Okay. Are you guys with me?
Yes, Doctor.
Yes.
Now, why is it important? Kenapa yang kita nak kisah sangat with this irregular heartbeat problem? Anyone?
Able to develop blood clot.
Yes, that's right. Very good. Those who answered, you see, because of this irregular pattern of your heartbeat, okay, this is an area of high velocity, okay. So if there is an irregular pattern of the electrical activity, blood clot can form over here at the right atrium, sorry, at the left atrium. And when blood clot occurs here, and then it travels through the ventricle and it gets pushed out, goes to your brain, it can cause a stroke. Okay, so that's why it's very important for us to detect atrial fibrillation as soon as possible, because we don't want them to get the complication of it, which is stroke. Okay, so there is a few different types of AF. Okay, so you have your first diagnosed AF, okay, irrespective of its duration or the presence and severity of the AF-related symptoms. You have your paroxysmal AF that terminates spontaneously, okay, or with intervention within 7 days of onset. When the patient comes to the hospital, we do an ECG. There is an evidence of AF, but then it terminates. It goes away after that, or within 7 days with intervention. So the third type is persistent AF that is continuously sustained beyond 7 days, including episodes that are terminated by cardioversion after 7 days or more. Meaning, if you have AF continuously beyond 7 days, you have persistent AF. You also have this long-standing persistent, whereby your AF is more than 12 months, and when you decide to adopt a rhythm control strategy. Okay, and lastly, you have permanent AF, whereby in this category classification, your AF is accepted by the patient and physician, and there are no further attempts to restore or maintain sinus rhythm. When I say restore, maintain sinus rhythm is when, you see here is a sinus rhythm. When your heartbeat is in a normal fashion, we call it is in a sinus rhythm. Okay, you can see a distinct PQRST wave. Okay, this is what happens in AF. You have this irregular heartbeat. So if you go to the hospital and the doctors can see this pattern of your ECG, that means you have AF. Okay, and in permanent AF, what happens is that the doctors said that there will be no further attempts to restore or maintain sinus rhythm, because sometimes this irregular rhythm is causing very bad symptoms to the patient. But in permanent AF, it's accepted that we're not going to do anything anymore. So we're just going to let the patient to be in this irregular heartbeat condition. That's permanent AF. Okay. Now, these are the risk factors. Who is at risk of getting AF? It can be seen in this slide. Like what I've said earlier, male sex are at increased risk of AF. Patients who are aging, okay, ethnicity and genetics, okay. Some other risk factors are like your concurrent medical illness such as hypertension, valve disease, heart failure, CAD, vascular disease, okay. You have your other diseases like your inflammatory disease, your obstructive sleep apnea. And you have your social history like your obesity, smoking, alcohol consumption. Okay, alcohol can also cause irregular heartbeat as well, lipid profile and activity. Now, because AF is rarely detected, it's not as common and easily detected by the normal public, we advocate a screening, okay? Like opportunistic screening for AF is recommended, okay, by pulse or ECG rhythm strip in patients above 65. Opportunistic screening means like whenever a patient comes to the hospital, for example, a cough or a flu for vaccination, okay, we take the heartbeat. Okay, I think that's what's being done worldwide. Okay, so when we see an excessive high heart rate, then that's when the doctors can further investigate via ECG. Okay, or if patients come in with ischemic stroke to the hospital, we need to check whether the stroke is due to AF, or when the stroke is due to AF, we call it cardioembolic stroke. And when the stroke is not due to AF, we call it ischemic stroke. Okay, so when these patients come to the hospital because of a stroke, we need to check the ECG whether the patient has AF or not, because then the treatment differs. Okay. So there are some other devices that can be used to screen AF. Okay, we have your Apple Watch. Okay, you have this lots of things that you can actually do to detect AF. Okay, my supervisors in England, they're quite what do you call creative actually. They put these devices at the hospital trolley. You know the trolley that we use, hospital, sorry, the supermarket trolley. The trolley that we use in the supermarket, kat Tesco ke apa kan, kita guna trolley kan. So kat situ diorang letak a sensor that could detect patients punya heart rate and dia punya ECG. So that sensor is connected to a computer, and whenever there is an abnormality in the heart rate or the rhythm, it will be prompted to the investigator to show that this patient might have AF. So that's how aggressive people are in the overseas to screen patients at AF. In Australia, I know every time a patient comes to the community pharmacy for whatever things that they want to buy or medication that they want to buy, they take this opportunity to ask the patient to check whether they have AF or not. If you watch the last video that I posted in your pre-class activity, kan, when the patient was talking about, when the nurse was asking the patient what do you do differently, kan, kalau you perasan, patient tu macam ada satu device, bila dia letak je dia punya jari, And then it's connected to a computer and then dia boleh detect whether patient tu ada AF ke tak. Siapa perasan? Perasan tak? Hello? Puan? Ke tak tengok lagi? Anyway, dia macam device tu macam tak ada kat sini, but it's like this lah lebih kurang. Ni smartphone, this is quite advanced jugalah. Okay, smartphone boleh. So anything that can detect whether the patient has AF or not. Kita kat Malaysia kita tak se-advanced ni. We have this Apple Watch and smartwatch, but I guess not everybody is aware of it. And even if they're aware, you know, they probably don't know what to do after that. Betul tak? Kalau kita detect heart rate kita tinggi pun, we just leave it as it is. Dia cakap tak apa, it will go away. Betul? So that's one kalau benda-benda macam kita tak apalah, especially after exercise, of course we expect our heart rate to increase, but we are talking about elderly patients who have all these risk factors. Okay, these are the patients that we want to create awareness so that, you know, if there is an irregular heart rate, where is increased heart rate suddenly, especially when they're resting, okay, when they're not doing any activity, we need to ask them to seek medical help as soon as possible. Okay, so how do you detect AF? Like I said, there are various methods here. Okay, but in order for you to diagnose AF, you have to present to the hospital and get it confirmed by an ECG. Okay, so that's why whenever you wear all these devices or you go and get yourself checked at the community pharmacy, we always have to tell them you need to go to your nearest hospital or clinic, get the ECG done and checked whether you have AF or not. So this is an ECG of your normal patient, okay, with a normal heart rate, and this is an ECG of your patient with an irregular heart rate. Like I said, AF diagnosis is made using an ECG that shows a typical pattern of AF involving irregular RR interval and no distinct P wave. Okay, this is your normal ECG. You have your P, Q, R, S, T. Okay, now in AF, okay, there is no P wave. Okay, there is no P wave. As you can see here, it's just so erratic. You see, there is no distinct P wave. Kalau macam ni kan, you're normal. You can see your P wave, but in AF it's so erratic. And then there is an irregular RR interval. So this is what you call RR interval. It's so irregular. So macam ni kan, in your normal, P, Q, R, S, T is very normal. But in EF, it's so abnormal. And any episodes of this abnormality that lasts more than 30 seconds is considered AF. Okay, patients with AF, they can be symptomatic. Okay, they can tell us that they have symptoms of AF, or they can be asymptomatic, which we call silent AF. In most of the time, 60% of the patient, they will be in the silent AF category. They don't notice that they have AF. And silent AF can have severe consequences such as stroke and death, just as with symptomatic AF. So when I say symptoms, what do I mean? Okay, what from what you have watched the videos, what are the symptoms of AF? Can you tell me? Can you share with me? Hello, anyone? Symptoms of AF? Okay, dizzy lagi. SUB tak sangat. Ya ada, but okay, tiredness. Lagi, what are the very common symptoms? Palpitations, Ada, that's right. Palpitation. Okay, Christina, that's right. See, because when you have this irregular heartbeat, you can tell usually the patients will say that you have a racing heartbeat or palpitation. Palpitation tu macam tu lah, heartbeat dia tu terasa laju. Okay, because there is rapid firing of the electrical activity of the heart causing this palpitation to happen. Okay. So when patients have AF, okay, you need to, of course, you need to obtain the medical history. You need to know, especially in patients with symptoms, we need to ask them how long they've had the symptoms, okay. We need to ask whether, what is the pattern, okay, is it at rest or is it during activity, okay. And then we need to check their concomitant condition, okay, whether they have, underlying hypertension or is it just AF, okay. And then we need to calculate the chart-VAS score. Now, anybody know what this chart-VAS score is for? One? No. No. Okay, we'll have a look at it. Okay, afterwards, what the chart-VAS score mean. Okay, and of course, we need to do ECG to confirm whether the patient has AF. We need to check for thyroid function test because hyperthyroidism can also, cause tachyarrhythmias. All right. You need to check your kidney functions, your full blood count. In some centers, we do transthoracic echocardiography, meaning we want to check whether there is a clot formation or not. But this is not too common in your hospital setting. Okay, in the government hospital setting, kita jaranglah buat transthoracic echocardiography. Now, so going to the clinical presentation of AF, like you have said just now, some patients they might not have any symptoms. Okay, like I said, silent AF. Okay, majority of the patient, in fact, about 60% of them have silent AF. Some patients might have symptom. Okay, like we've said just now, palpitation, dyspnea, fatigue, because not enough blood is being supplied to your other organs, especially to your brain and stuff. Okay, you have syncope, you have dizzy, okay, sleep disturbance, and so on and so forth. Okay, many of the patients, they are quite stable. However, if they are hemodynamically unstable, okay, for example, they have syncope tu pingsan, okay, symptomatic hypertension, okay, BP dia rendah, okay, causing them to have dizzy, okay, when they have acute heart failure or pulmonary edema, when they have ongoing myocardial ischemia, cardiogenic shock, you have to bring them to the emergency department as soon as possible. Okay, this has to be dealt within a very short period of time. Okay, whereas if you are stable, okay, you can go to your KK Klinik Kesihatan and get yourself checked lah. Okay, kalau tak stable, you need to go to the ED as soon as possible. Now, why, like I said, why is AF important? Because of these outcomes. Okay, when you have AF, you have an increased risk of death. Okay, 1.5 to 3.5 higher risk of death. You have higher risk of stroke, like I said. Okay, that's what we are scared of in AF. We want to prevent the stroke. Okay, so like I said, when you have stroke due to AF, it's called cardioembolic stroke. Okay, you are at increased risk of getting heart failure. Okay, in about 20 to 30% of the patient. You are at increased risk of having vascular dementia. Okay, depression, impaired quality of life, and hospitalization. So that's why we need to we need to detect patients with AF because we don't want them to get all these outcomes, especially stroke. Okay, are you guys with me?
Yes.
All right, so in those with symptoms, there is a modified European Heart Rhythm Association ERA symptom scale. Okay, when they come to the clinic, we have to rank their symptoms according to this ERA score. So ERA score of 1 means they don't have any symptoms. Okay, 2A is mild symptoms. Okay, what do you mean by mild is that your normal daily activity is not affected by the symptoms, meaning it's just mild palpitation, you can still do your normal activity. 2B is moderate. Okay, normal daily activity is not affected by symptoms related to AF, but patients are troubled by the symptoms. Okay, sebab dia rasa macam tak selesa lah, sebab dia rasa macam tapi dia still boleh buat normal activity. Dia boleh pergi shopping, dia boleh pergi, they can cook, they can do whatever they want. Tapi kadang-kadang bila dia rasa dia trouble sikit lah, so that's to be moderate. You have severe symptoms, 3, category 3, whereby your normal daily activity is affected. Okay, maknanya bila you nak masak je, you dah rasa that palpitation is affected. Rasa macam kadang-kadang rasa macam tak selesa. Okay, and in category 4, it's disabling, whereby you tak boleh nak buat the activity tu because you terlampau, you are too affected by it. Okay, sampai you tak boleh nak, you cannot cook, you cannot shower, you cannot jog. Okay, because whenever you do those things, you can feel your heart racing, or you're just too tired, or you're just too dizzy. Okay, so that's category 4. Now, to be honest, when I was dealing with this AF patient, majority of the patient is in ERA score 1, or even there is some in mild category. Jarang kita, I don't know lah, for me, from my experience dealing with AF patients, it's very not many patients are affected by the symptoms. Not many of them are in category 2B and above, which is good lah. Okay, but bear in mind, even if they don't have symptoms, okay, but if their heart rate is high and they have irregular rhythm, they need to be properly checked and managed, because we don't want them to get to get the complication first baru masuk hospital. Itu kita tak nak lah, because the symptoms is so it doesn't happen so normally, so regularly, like your heart attack kan ada chest pain and whatnot. Sama macam hypertension. Hypertension pun is asymptomatic. In all these cardiac condition yang tak banyak sangat symptom ni, we need to be very careful with the patient. When we are explaining to the patients, no symptoms doesn't mean that you are okay. Okay, you have to get yourself checked and monitored. Okay, because many patient, including family members, kan, bila dia cakap hypertension dia okay, tak ada rasa apa-apa pun. So because of that, they don't want to take their medication and they don't want to go for monitoring. Okay, they don't want to follow up and whatnot. So that's what we don't want lah. We want to educate the patient to keep on going for follow up and taking their medication. Now, so how do you want to manage AF? Okay, especially this is talking about stable patient, yeah. Bukan yang hemodynamically unstable. These are stable patients. Okay, so first of all, the main priority in us managing AF patients, first of all, is we want to avoid stroke. Okay, because stroke from AF is worse than your normal ischemic stroke. Okay, so how do you want to avoid stroke? We can give oral anticoagulants, okay, be your VKAs, vitamin K antagonists, or NOACs. Okay, siapa tahu apa contoh VKA?
Warfarin.
Yeah, that's right. Shafiq, that's right. Okay, VKA contoh warfarin, NOACs contoh, anyone? Anyone? from your pharmaco days? NOACs, what's an example of NOACs?
Apixaban.
Yeah, apixaban, dabigatran, that's right. Thank you very much. Okay, rivaroxaban, okay, and edoxaban. Yang paling baru sekali, we call it edoxaban. Okay, first of all, we want to avoid stroke. Okay, second of all, we want to manage the symptoms. Okay, kalau patient complain of symptoms, we want to manage them. Okay, using either a rate control strategy or a rhythm control strategy. Okay. So rate control strategy, you can either give your beta blockers, okay, your non-dihydropyridine CCB, digoxin or amiodarone, or rhythm control therapy. Can give you antiarrhythmic drugs, or it can also be done by electrical cardioversion. And you want to manage other comorbidities, okay? So please, this is the patient care process for patients with EF, and this is available from your pharmacotherapy book. Okay, when a patient comes in, okay, these are the 5 steps that you need to do when a patient comes in, okay, for AF. Okay, first of all, you want to collect the information like what we've talked about previously. You know, you want to know the patient characteristic, the other presenting illness, social history, whatever medication that they're taking, okay. Of course, you want to collect objective parameters like your blood pressure, yeah, like your heart rate, height, weight, because you want to see whether the patient is obese or not. Okay, you want to check their labs, like their electrolytes, okay, their serum creatinine, especially if you know, if we were to start with the NOAC, we need to make sure that patient's creatinine, serum creatinine is normal, okay. And if patient were to start on warfarin, we have to check the INR. Okay, and of course, we need to confirm the EF with an ECG. Then after we collect all this information, we have to assess, okay, whether the BP is normal or not, whether there's an evidence of heart failure or angina, how long they've had the EF symptoms, okay. We want to check their risk of stroke with this chart VAS score and the risk of bleeding with the HASPLET score. Okay, we will talk about it later. Okay, we want to see whether there is a presence of potentially reversible causes of AF, like I said, thyrotoxicosis, thyroid storm, alcohol withdrawal, infection, electrolyte abnormalities, okay, like your hypokalemia, hypomagnesemia can cause AF as well. And then we want to check whether the patient is able or willing to pay for anticoagulant treatment options. Okay, like I said just now, anticoagulant, they can give your vitamin K antagonist, which is the cheaper option and the what we usually use in the public setting in Malaysia. Or, you know, if you don't want to use the VKA because of monitoring, you can offer them a NOAC, okay, or a DOAC, okay. But then the patient will have to pay on their own, right? Okay, then a potential drug interaction, okay, especially with drugs with rate control medication, anticoagulants, and antiarrhythmic. Then you need to plan. Okay, after you assess all these things, you need to plan what you want to do with the patient. Okay. Okay, what drug regimen that you want to include, rate or rhythm, anticoagulant, the dose, frequency, and duration. Okay, monitoring parameters, of course, you need to check for efficacy and safety of all those drugs, okay, especially, you know, when you give something, of course, you want it to be effective, especially if you give a rate control therapy, you want to make sure that the rate is being controlled. If the rate is sky high, 180, of course, you want to bring it down to your target rate, heart rate, which we will look in a minute, okay, and rhythm, you want to make sure it goes back to sinus rhythm, okay, if it's not permanent AF, okay, and safety, especially if you're dealing with anticoagulants, you have to check whether there is an increased risk of bleeding, okay, and when you're using all this rhythm control therapy, you need to check for the side effects like this ventricular tachycardia, torsades de pointes, and then you need to implement education, okay, motivational interviewing, and then adherence. Okay, and then those patients with warfarin for their stroke prevention, you need to ask them to come back for the INR monitoring. Okay, And lastly, when the patient's already put on all this medication, you have to monitor and evaluate. Okay, like I said, whether the rate has been controlled, rhythm has been in sinus rhythm, are they having any more symptoms, are they having any side effects, and of course, you want the INR to be within the target range of 2 to 3 if the patient is on warfarin. And of course, whatever treatment that we give, we need to make sure that the patient adhere to the treatment. They need to understand why they have to take all this treatment, and they need to, be able to be aware that if they don't take this medication, what will happen to them. Okay, we need to instill that in the patient, instill that responsibility in the patient, because if we as a healthcare provider, we just ask them and force them to take, but they don't understand why they have to take. That's why they don't want to take it. Okay, because they didn't understand. They have lack of knowledge. Okay, now this is a atrial fibrillation beta cap pathway that's been produced by my supervisors in England. Okay, so it's very simple. It actually summarize what you need to do in patients with AF. So you have your A, which is to avoid stroke, and how you want to avoid stroke. There is a Birmingham 3-step way. Okay, first you identify low risk patients. Okay, then you offer stroke prevention to patients with more than one risk factors of stroke. Then you assess their bleeding risk. And then step 3, you decide on the oral anticoagulation therapy, either with a VKA, with a well-managed time intermittent range, or a NOAC. Okay. The second step, the B, is better symptoms management. You treat the symptoms, okay, and it has to be patient-centered and symptom-directed decision on rate versus rhythm control. Okay, we have to decide whether we want to do the rate approach or rhythm approach. And lastly, cardiovascular risk factors, you want to manage them. That means if they have hypertension, we have to make sure that they are on correct treatment. Okay, if they have heart failure, make sure we check their ejection fraction, and we address all these issues, not just leave the patient on their own. Okay, so when we're looking at the patient, we have to look at the patient as a whole, not just one individual with one problem. Okay, of course, we have to encourage lifestyle changes, like if the patient is obese or overweight, we need to address that. Okay, regular exercise and reduce alcohol, psychosocial, psychological morbidity, and consider patient values and preferences. So in the ESC guideline, they have highlighted that in managing patients, you have to put the patient in the center. Okay, we have this thing called patient-centered care. Patient has to know and they have to aware that they are responsible of their own self, and they have to be in the team. They have to, whenever the doctors are giving them options, they have to be a part of them. Okay, like doctors say, okay, there's 2 drug treatments, drug A, drug B, what would you prefer? That's what we call patient-centered. We bring the patient together in deciding what treatment works best for them. Okay, so bila kita buat macam tu, baru patient tu ada kesedaran lah, not just one way kan. Macam kat Malaysia kan, kita selalu put the decision making to the doctor sahaja. Kita akan cakap, doktor decide lah untuk saya follow je. That's what we usually do in Malaysia, but we want to change this mindset. Okay, we want the patients to be together deciding what therapy works best for them. Okay, in terms of stroke prevention or rate and rhythm control and management of other cardiovascular comorbidities. Now, in stroke prevention, like I said, the first priority is stroke prevention. Okay, and how do we do this? Okay, we first of all, we need to check their stroke risk. And how do we do that? We use the chart bar score to stratify the patient at risk. Okay, And how do we do that? We give oral anticoagulants, like I said, with your VKA or your NOACs, and you assess your bleeding risk. Now, this is the chart VAS score, okay? Which patient needs stroke prevention? You need to use the chart VAS score. It has a class 1A evidence, okay? You need to use this score in patients with AF to know whether they're at risk of stroke or not. Like I said, okay, this is the chart VAS score. Okay, C stands for congestive heart failure. If the patient have heart failure, give a score of a 1. If they have hypertension, you give a score of 1. If their age is 75 years or older, you give a score of 2. Diabetes mellitus, 1. Previous stroke, a 2. Vascular disease such as your myocardial infarction, PAD, or aortic plaque, you give a 1. If the patient is between 65 to 74, give a 1. And if the patient is female, you give a 1. So what you do is you calculate the score. Okay, when you see the patient for the first time, you need to calculate the score and what the score means. Okay, if the patient is male and they have a score of 0, okay, that means they are at low risk of stroke. Okay, or if they are female, okay, tengok kat sini ya, female ni dapat 1 skor tapi dia tak ada problem lain, they at low risk of stroke. So what you do? You don't give any anticoagulant therapy. Now the minute they have 1 score or greater, okay, you have to give oral anticoagulant. So remember, like I said just now, first you need to check whether the patient punya risk of stroke. Kalau low, tak payah bagi anticoagulant therapy. Kalau dia moderate or high, you need to give anticoagulant therapy. Faham tak? Guys, are you guys with me? This is very important. You need to know how to calculate the chart VAS score. Okay? Are you guys with me? Hello? Okay. Now, this is the flow diagram, like I said, okay, in patients with AF, okay. You need to identify the low risk patient. First of all, before you identify, you need to check whether the patient has any heart disease before, a valvular heart disease, okay, like whether the patient is on prosthetic mechanical heart valve, or they have moderate to severe mitral stenosis. Yang ni biasanya, this is very technical, the doctors will identify lah all these things, okay. If they are in this category, the oral anticoagulant that they can take is VKA. Now, if they are not in this category, okay, they don't have any prosthetic. Prosthetic ni heart valve yang kita letak apa ni? Prosthesis lah yang bukan yang normal heart valve. Maknanya masa dia kecil-kecil dia ada problem dengan heart valve dia. They need to get prosthetic heart valve lah, sama ada from the PIC or yang apa ni, mechanical ni yang mechanical lah. Okay. So kalau dia tak ada masalah valve, okay, they don't have any valve issues like normal patients like you or me or anyone yang tak ada heart valve problem. Okay, first of all, you need to identify, okay, which risk they belong to. Okay, so kalau they are at low risk of stroke, okay, maknanya yes ni, you don't need to give antithrombotic. Antithrombotic tu anticoagulant lah, okay. But if they are not in the low risk of stroke, you go to step 2, straight away you need to you need to calculate the punya chart VAS score and the punya Hasblad score. Hasblad score ni is a score to look at the risk of bleeding. We will look at it later. Okay, chart VAS score. So kalau chart VAS score dia more than 1 in male and more than 2 in female, you need to give oral anticoagulant therapy, NOAC or VKA. But the ESC guideline has generally recommended NOAC as the first line therapy for oral anticoagulant. Okay, this is what has been recommended by the ESC guideline lah. Okay, tapi kat Malaysia, kebanyakan hospital kerajaan kita still guna VKA lah because NOAC ni is expensive. Okay, so we still use VKA unless if the patient is willing to buy NOAC ni kat luar, kita boleh bagilah that option to the patient. Okay, so kalau patient nak VKA, your vitamin K antagonist, okay, they have to make sure that the INR is within the therapeutic range of 2 to 3. Okay. So ni for example vitamin K antagonist is like your warfarin. You have your 1 milligram, 3 milligram and 5. So usually kita bagi tahu kat patient pilih warna brown or blue or pink. Okay, sebab dia tak ingat lah. Usually patient tak ingat. Sometimes why there are many strength, because warfarin is very has a low therapeutic index. So bila kita adjust dosis sikit, dia sama ada boleh level dia boleh tinggi sangat ataupun boleh rendah sangat. So kadang-kadang kita kena combine to get the therapeutic effect dia. Okay, warfarin is good. Okay, it's very effective. Okay, it reduces the risk of stroke and systemic embolism by 64%. So it's a very effective drug, and it reducing all-cause mortality by 26%. Okay, compared to antiplatelet therapy, those suggested VKA was more efficacious in the reduction of TE complication. Okay, dulu memang diorang guna aspirin, tapi nowadays we have stopped recommending aspirin. Okay, for stroke prevention, we need to give your oral anticoagulant. So one of it is called vitamin K antagonist. Now, is the commonly used anticoagulant indicated in the prevention of thrombosis and thromboembolism? Okay, it is very non-specific agent. Okay, as you can see, it blocks at factor 2. Okay, 7. Okay, it blocks at factor 2. Blocks at factor 7. Okay, 8 and 9. So kalau you nampak kan, warfarin ni very non-specific. It blocks at so many pathways, and hence that's why it's so difficult to get a good control with warfarin. Okay, if warfarin is to be used, a target INR of 2 to 3 is recommended. Okay, with the class 1B. So kalau patient tu tak capai INR range ni, kalau dia punya INR range dia is less than 2, okay, the patient is at risk of stroke, meaning the dose is not enough to produce the effect. Okay, if the INR is above 3, that means the patient is at risk of bleeding. Okay, maknanya dose tu mungkin terlampau tinggi untuk patient. So kalau you perasan 2 to 3 ni is very narrow. So susah, in most of the time it's so difficult to get the patient to be in this range, because satu lagi warfarin ni is it has many drug interaction, it has many food interaction, banyak pantang larang dia. So because of those problems, they've come up with the newer oral anticoagulant. Okay, for example, you have your factor, these are more specific lah. Okay, you have your factor 10A inhibitors, it just block here. Okay, for example, your apixaban, edoxaban, rivaroxaban, or you have your direct thrombin inhibitor like your dabigatran, it blocks here. So at the end of the day, we actually want to block the formation of fibrin. Fibrin is the clot lah. Okay, we want to prevent the clot formation. So via all these pathways lah. Okay, so these are the newer oral anticoagulants. Okay, like I said, and these are more specific. It doesn't have any food, and it has less drug interaction. However, when you want to use the newer oral agent, you have to check the RP renal profile, because most of these agents, they are cleared renally. Okay. Now, these are the trials that we use to look at the newer drugs. You can have a look at these trials later on. Okay. Now, this table looks at the characteristics of VKA and NOACs, advantages and the disadvantages. So, in essence, basically, kalau you nampak ni disadvantages dekat vitamin K antagonist ni, it has an unpredictable pharmacokinetic and individual reaction. It has a lot of drug-drug interaction. You need dietary restriction. Patients need to come to the hospital to monitor their INR. Okay, in the initial stage, they will need to come every week, and then depending kalau INR is stable within the range 2 to 3, then once a month, okay, every 6 weeks. Okay, so troublesome lah, it's very troublesome for the patient. Okay, they have a narrow therapeutic window, like I said. Kalau INR less than 2, the risk of stroke is high, and INR above 3, the risk of bleeding is high. Okay, it is a slow onset and offset drugs. It has a long half-life, and tengoklah dia banyak sangat disadvantage dia. Okay, but because of that, they come up with the new agents like Bigatran and so on. Okay, one good thing about this warfarin is that there is antidote. Okay, whereas in the new NOACs, there's only an antidote for dabigatran. So maknanya kalau patient comes in with bleeding, okay, kalau dia on warfarin, kita boleh bagi vitamin K lah. That's the antidote for warfarin. Whereas kalau dia datang with a bleeding, with a very bad severe bleed, for example, hemorrhagic bleed in the brain, kalau dia on NOAC, kita tak ada antidote. Hanya ada antidote sekarang ni untuk dabigatran saja. Okay, kalau dia on other NOAC, we just give supportive therapy lah. That's one disadvantage about. Okay, now like I said, we have to monitor the risk of bleeding because anticoagulants ni they are at risk of putting the patient at risk of bleeding. Okay, so this is a way. A Has blood score ni is a score to check the bleeding risk. Okay, so you calculate lah macam tadi Chava score untuk check risk of stroke, whereas Has blood score untuk check the risk of bleed. Now if the patient has 1, that means low risk of bleed, 2, intermediate risk, and more than 3, high risk of bleeding. Okay, whatever the score is, it's not a reason for us to withhold the anticoagulant therapy. Okay, even if the score is more than 3, kita tak withhold lah. Okay, unless the patient datang with, like I said, with like intracranial bleed ataupun GI bleed. Okay, because dia ambil warfarin, then we need to withhold sekejap. Okay, address the bleeding issues and then restart again. Okay, so the ESC guideline has recommended, okay, have given all this recommendation. You can have a look, like I said, you know, in patients with AF, you need to check the risk of stroke, okay, by the CHAPA score. Okay, there's a class 1A evidence. Okay, it's recommended in patients with a high CHAPA score. Okay, semua 1A evidence ni. And this you can have a look. Okay, the ESC guideline has recommended kalau nak guna oral anticoagulant therapy. Okay, NOAC is recommended. Tapi kalau VKA nak use, make sure it has to be within the range of 2 to 3. Okay. Now, the second, what time is it? Dah 1 jam. Can I extend this a bit or you guys want to stop? Habis lagi ni. Right. So tadi kita dah, I ambil sikit lagi masa you all okay. I hope you don't mind, right? So tadi we've looked at the first priority, which is to prevent stroke. Now the second part is to manage the symptoms, okay? If the patient come in with symptoms, okay, we want to manage them. How? Okay, like I said, there are 2 strategies, okay, rate control therapy or rhythm. Now let's look at the rate control therapy first, okay? So ventricular rate control can be achieved by inhibiting the proportion of electrical impulses conducted from the atria to the ventricles through the AV node. Now, drugs that are effective for ventricular rate control are those that inhibit AV node impulse conduction, such as your beta blockers, okay, your non-dihydropyridine CCB. So bear in mind, this is your non-dihydropyridine CCB, like diltiazem or verapamil, digoxin or amiodarone. So maknanya rate control therapy ni is a strategy kalau patient ni datang and then dia punya heart rate dia above, your normal heart rate is 90, betul tak? So if their heart rate goes above that, above 90, for example, kalau patient datang with a heart rate of 140 or above 90 and they are AF, so if you want to reduce the heart rate, okay, we can give rate control therapy. Okay, the target that we want Okay, the target heart rate is less than 110. Okay, so how do you want to apa ni? To manage this? Okay, in patients who present to ED with an episode of symptomatic persistent AF or paroxysmal AF, in which intervention is desired, ventricular rate control is usually initially achieved by using IV drugs. Okay, kalau rate dia terlampau tinggi, dia datang ED, dia kata I cannot sleep, I cannot do anything, I have palpitation, I'm dizzy all the time, and when you do ECG, it's AF, and rate dia 180 for example, okay? And the doctor say, okay, look, we need to control your heart rate. So in general, in the acute phase, acute mean and in the phase yang awal-awal yang patient datang lah, okay? In general, you can give an IV drugs, okay? For example, your IV CCB or beta blockers, okay? It's preferred for ventricular rate control in patients with normal LV function, okay? Because ventricular rate control can often be achieved within several minutes. Okay, so maknanya kalau left ventricular function dia normal, kita can give IV CCB or beta blockers. Okay, what I meant by LV function is your left ventricular function. When you do your heart failure punya lecture, you will know what it means lah. Because usually kita patients yang ada heart disease ni, biasalah kita akan monitor dia punya left ventricular by doing echo. Okay, so a value of more than 40%, an ejection fraction of more than 40% means that you have a good LV function. Okay, whereas in an echo, in the ejection fraction less than 40%, that means you don't have a normal LV function. You will learn more about it in your heart failure punya topic lah. Okay, so what happens kalau patient tu ada abnormal LV function or they present with acutely decompensated heart failure, okay, or heart failure with reduced ejection fraction, ni lah yang cakap tadi. Reduced ejection fraction is when dia punya ejection fraction value is less than 40%. You can't use your IV CCB. Okay, LV and non-dihydropyridine CCB, for example, diltiazem should be avoided. Okay, please take note of this. It should be avoided as these drugs can cause negative inotropic effect and it may cause worsening of the heart failure. So in these patients, you can either give when they're a bit stable, okay, you can give an IV beta blockers, okay, but only if they're a bit stable. Or if you need to achieve rapid AF, okay, you can give digoxin. Okay, so this is the diagram lah, okay, on how you want to manage the patient with high heart rate. Okay, first of all, you need to assess comorbidities. Okay, like I said, I'm just repeating what I've said just now. Kalau dia tak ada masalah apa-apa or they just have hypertension with a normal ejection fraction, okay, first line you can give beta blockers, okay, or your non-dihydropyridine CCB. For example, diltiazem nifedipine. Now, kalau dia ada heart failure with reduced ejection fraction, okay, dia tulis kat sini first line ni beta blocker. Tapi beta blocker ni hanya bila patient ni is a bit stable. Kalau dia tak stable waktu tu, maknanya what I mean by tak stable, hemodynamically unstable, contohnya BP dia drop, heart rate dia drop, okay, dia unconscious, okay, dia ada severe SOB, dia ada pitting edema. Those are the normal symptoms, signs and symptoms of heart failure. We cannot give beta blocker yet. We give digoxin. Okay. See, like I said, if there is a suboptimal rate control, ini kan, this is when the patient is stable. Kalau dia tak stable, don't give beta blockers yet. Okay, because beta blocker ni dia akan block contraction of the heart and make it worse. This is a diagram for patient yang dah stable. There's another diagram for patient yang tak stable. Okay, and then you need to see whether patient has COPD or asthma or not. Okay, so kalau dia ada, of course you don't want to give beta blockers yet. Okay, you want to give other option like your non-dihydropyridine CCB. Okay, then you tengok, you assess the patient. Like I said, you are targeting a heart rate of less than 110. Okay, kalau you have suboptimal rate control, lepas you dah bagi ni, heart rate dia lebih, still lagi above 110, and the patient has worsening symptoms or quality of life, you can consider second line treatment. Okay, macam tadi, kalau first line you dah bagi beta blocker, second line you can give other agent lah. Contohnya dihydropyridine or digoxin. Okay, this diagram ni untuk stable patient let me repeat again, this is for stable patients yang hanya datang untuk follow up dekat klinik. Okay, kalau yang unstable patient datang dekat ED, the way you want to treat the patient is slightly different. Okay. And then after you consider second line treatment tak jalan, you can add a third line treatment, or you can consider other surgical therapy lah. Now these are the drugs, the individual drugs, okay, for rate control. Okay. Like your beta blockers ni, you can have a look lah later. Okay, kalau patients have acute exacerbation of asthma, it is contraindicated. Okay, in acute heart, it's contraindicated in acute heart failure and a history of severe bronchospasm. Okay, you have your non-dihydropyridine CCB is also contraindicated in patients with heart failure with reduced ejection fraction. Okay, in this patient, like I said, your option would be digoxin. Okay. However, digoxin ni selalunya kita guna at the acute stage sajalah. What I mean acute tu masa dia kita nak stablekan dia. Okay, because digoxin ni you kena buat DM and then you have to check renal function. So banyak cekadat dia lah. Okay. You can still use but short term. Or in cases where the patient tak boleh tolerate digoxin, you can give amiodarone. Okay, but it is contraindicated in patients with thyroid disease. Okay, so these are the recommendations for ventricular rate control in patients with AF. Okay, stable AF. So beta blockers and non-dihydropyridine CCBs are recommended as first choice drugs to control heart rate in patients with left ventricular ejection fraction more than 40%, class 1B. Okay, kalau dia less than 40%, you can give beta blockers or digoxin. Tapi like I said, beta blockers ni hanya kalau patient tu stable saja. Kalau tak stable, you can straight away give digoxin. Okay, resting heart rate of less than 110 can be aimed lah in patients yang ada high heart rate. Okay. Now, finish about the rate control therapy. Moving on to rhythm control therapy. So why do we need to use rhythm control therapy? Strategy is to convert to sinus rhythm. So remember what I said just earlier this lecture. Maknanya kalau rhythm dia tak cantik, okay, you want to convert back to sinus rhythm, you can use the rhythm control strategy. Okay, and this can be done via drugs ataupun okay, it can be done by antiarrhythmic drugs, okay, AED, or you can do it with elective direct current cardioversion. Ini you bagi current lah dekat the heart tu. Okay, so this agent is slow atrial conduction velocity and prolonged refractoriness, facilitating interruption of re-entrance circuits and restoration of sinus rhythm. So in general, okay, direct current conversion is more effective than drug therapy. Okay, however, patients who undergo elective DCC they have to be sedated and anesthetized to avoid the discomfort associated with delivery of 120 to greater jolts of electric to the chest. So maknanya bila kita nak guna DCC ni, we're actually applying electric shock dekat jantung. So they have to be sedated. Yang macam kita tengok kat movie tu kan. So they have to be sedated. And sometimes they need to be given oral anticoagulant to prevent from developing clots. Okay, so therefore it's important that patients schedule to undergo elective DCC. They do not eat within approximately 8 to 12 hours of procedure to avoid aspiration. Okay, if a patient presents with AF requiring non-emergent cardioversion to sinus rhythm and the patient has eaten a meal on that day, pharmacological conversion method must be used on that day. So this is Okay, I will skip. Okay, rhythm control therapy is recommended for symptoms and quality of life improvement in symptomatic patients with AF. Usually rhythm control therapy ni kita adopt bila kita dah try rate control therapy and dia tak berkesan. Maknanya kita dah cuba bagi your rate control therapy either with beta blocker, CCB or digoxin. Dia still cakap, oh, I'm still having symptoms. So we can try giving rhythm control therapy lah. Okay, ini cardioversion, tak apa, you boleh tengok. Okay, so what are the drugs that we can use to restore sinus rhythm? Okay, you can use these are the drugs. You can use your flecainide, propafenone, okay. You can use vernaculan. Ini tak ada kat Malaysia. Amiodarone now. Bear in mind, amiodarone ni dia ada dua property. Okay, dia ada rate control property and dia ada rhythm control property. Okay, so kalau you nak achieve both, you can give amiodarone lah. Tapi amiodarone ni dia banyak cekadak dia juga. Dia banyak contraindication. It can cause hypertension, bradycardia, atrioventricular block, QT prolongation. So, like I said, amiodarone ni pun nak guna short while boleh, but in long term, we usually stop lah because dia ada banyak problems. Okay, so if a patient for long term rhythm control therapy, kalau katakanlah kita dah try, like I said, dah try rate control therapy, dia tak jalan, dia cakap, okay, I want to try rhythm control therapy. Dia cakap kat doktor lah, maknanya I'm still having symptoms of AF. Okay, I'm bothered by it. So tengok kat sini patient choice. Maknanya patient yang nak. So what do we offer to the patient? Again, we need to see whether the patient has any signs and minimal signs of structural heart disease ke tak. Kalau ada, these are the options. Okay. Kalau patient ada coronary artery disease or heart failure with preserved ejection fraction and significant valvular disease, we can either give amiodarone, ronidarone, sotalol. Okay, kalau patient ada heart failure with reduced ejection fraction, maknanya dia punya ejection fraction dia less than 40%, the only option yang kita ada is amiodarone. Okay, tak boleh bagi sotalol. Kalau you perasan ni lah. Okay, maknanya kalau patient tu on sotalol before this, and then tiba-tiba next follow up, bila dia orang buat echo, ejection fraction dia menurun. It's less than 40%. We need to stop the sotalol and give amiodarone. Okay, this is one thing that you need to know lah. In patients with heart failure with reduced ejection fraction, tak boleh bagi sotalol and the only option that they have is amiodarone. Okay, so this is the principle of antiarrhythmic drug therapy. Okay, it is aimed to reduce AF-related symptoms. Okay, the efficacy of antiarrhythmic drug to maintain sinus rhythm is modest. Modest ni maknanya tak berapa cantik sangat lah. Okay, clinically successful AED therapy, it may reduce rather than eliminate AF recurrence. If one AED fails, a clinically acceptable response may be achieved by another drug. Drug-induced pro-arrhythmia or extra cardiac side effects are frequent. Safety rather than efficacy consideration should primarily guide the choice of antiarrhythmic drug therapy. So, who is indicated for antiarrhythmic drug therapy? Like I said, is the patient symptomatic? Okay, if lepas kita dah bagi rate control, kalau dia still complain of symptoms, then we can give rhythm control therapy. When to start? Usually not the first episode, but it may enhance efficacy of cardioversion. How to choose? You want to choose the drugs that has the minimum pro-arrhythmic risk and organ toxicity. Okay, you boleh baca lah. Okay, you boleh baca. These are the agents that you can use for rhythm control therapy lah. Okay, and dia punya dose, dia punya contraindication, precaution, comment dia. Boleh baca lah ni Now, so macam mana kita nak choose rate versus rhythm? Okay, like I said, it's always a debate. Okay, But like I said, rate control therapy is strongly preferred as the initial approach in elderly patients with minor symptoms. Okay, rhythm control therapy is strongly preferred in patients with symptoms despite rate control. Okay, including those with persistent symptoms of heart. Maknanya kalau kita dah try rate tak jalan, baru kita start with rhythm control therapy. Okay, rhythm control therapy is weakly preferred as an initial approach. Okay, and rhythm control is weakly preferred in patients with AF secondary to a trigger or substrate has been corrected. So in essence, in summary, memang kita try rate dulu, tak jalan baru kita try rhythm control therapy. Sebab rhythm control therapy drugs ni dia banyak terlarang, banyak dia punya you have to monitor, banyak can cause cardiotoxicity and so on and so forth. Okay, and contribution of AF risk factors to the development of abnormal substrate translating into poorer outcomes with the control strategy. Maknanya kalau patient ada all these risk factors, dia akan menyebabkan for example hypertension, control hypertension, physical inactivity, dia ada masalah yang lain, lagi susah kita nak achieve dengan rhythm control therapy. Okay. Habis. Oh my God. Right, I'm finished with the lecture. Let's look at the case. Anyone want to volunteer to read the case? Please. We 10 o'clock yet. You have another class, right? Hello? Hello? Anyone want to volunteer to read the case?
I can.
Yeah, please go ahead.
A 42-year-old male with no past cardiovascular medical history comes to the ED with a complaint of shortness of breath and lower extremity edema for 1 month. He is febrile with a heart rate of 160 beats per minute, respirations of 20 per minute, blood pressure of 140/90 mmHg, and oxygen saturation of 92% on room air. His jugular venous pressure is markedly elevated. Lung exam reveals diffuse rales. 2/6 systolic ejection murmur is appreciated at the right upper sternal border. An S3 heart sound is present and the point of maximal impulse or the PMI is laterally displaced and no S4 is heard. There is 3+ pitting edema up to his knees. His ECG confirms atrial fibrillation with an uncontrolled ventricular rate. What is the most appropriate initial management?
Right. So, what do you guys think? What do you think is the answer? Anyone? Should we give let's look at the case. Okay, we have a 42-year-old male. Dia datang ED lah with a complaint of SOB and lower extremity edema for 1 month. Okay. Dia ada heart rate 160 beats per minute. Okay. Pulse rate respiration dia okay, BP dia okay, oxygen saturation dia not that great, 92. Okay, JVP is elevated. Okay, so when you look at the case kan, patient ni ada SOB, lower extremity, JVP dia tinggi. Okay, and dia ada AM, right? So what can you understand from this case? Dia ada AF, dia macam tak berapa nak stable sangat. Okay. Kalau tak berapa stable, dia stable. Cumanya dia ada SOB, dia ada SPO2 dia rendah sikit. Okay. And JBP tinggi. So what do you think? So patient ni probably might have a bit of a heart failure tapi kita tak confirm, betul tak? There's no ejection fraction. So bila remember when we want to okay, we want to adopt macam ni kan, is doktor ni dia nak I think dia nak control the ventricular rate because tinggi sangat kan 160 ni. So what options do you have? Remember yang kita tengok tadi, okay? What options do you think we have? Do you want to go for let me do a poll here. Anyone want to poll? Be Daron ke nak bagi I Light ke nak bagi IBCCB ke Joxin CC. Dah keluar ke tu?
Dah keluar dah.
Tell me what you think. It looks like most of you answered IBCCB or beta blockers. Okay, 18% of you answered yang itu. Some would say IV amiodarone. Some would say digoxin. Banyakkan cakap IBCCB beta blockers lah. Okay, so I'm going to close the poll now. I can see that majority answered IV, CCB or beta blockers first. Now this is the answer here. Okay, the patient's heart rate is significantly elevated in the setting of AF and he is hemodynamically stable. Thus, slowing his heart rate with non-dihydropyridine CCB or beta blockers is reasonable. So you're right. Okay, so the answer is C. Okay, very good. Okay, converting his rhythm to sinus is not the initial approach as the patient is hemodynamically stable. And further investigation need to be performed first to determine the etiology prior to restoring sinus rhythm. Digoxin alone is not generally recommended to lower heart rate in AF patient and is best used when systolic heart failure is present but long. So maknanya kita tak nampak macam patient tu nampak macam stable tu, tapi dia adalah sikit-sikit sign and symptoms of heart failure, but we don't have an objective parameters. For example, dia punya left ventricular ejection fraction dia kita tak ada value dia lagi. Okay, katakanlah ada value dia tulis ni patient is in the decompensated heart failure state and his ejection fraction is 30%. Then answer C ni salah lah. Okay? What would be the answer? Kalau patient ni ada heart failure, what would be the answer? Anyone? Yep. Anyone? Kalau patient ada heart failure, what would be the answer? Anyone? No? No takers? Kalau dia ada acute heart failure, kita tak bagi beta blockers dulu. Okay, especially kalau dia ada acute exacerbation of heart failure, kita bagi digoxin. Yes, Atika, you're right. Kalau dia dah a bit stable, punya heart failure dia dah a bit stable, baru kita bagi beta blockers lah. Okay. Now, next question. I know I'm taking some time, but this is a very important topic, so I really need you guys to understand lah. Anyone, any volunteers to read this case? Yo,
I will read the case, doctor.
Aziza.
Yes, okay. A 65 years old female with a history of hypertension but otherwise healthy present for evaluation for palpitations. Her vital signs are normal and a 12-lead electrocardiogram is normal. An ambulatory ECG monitor confirms that her palpitation correlated with paroxysmal atrial fibrillation with heart rates of 150 beats per minute. She started on long-acting diltiazem. Which of the following would be an additional appropriate recommendation?
What do you guys think? Right. Can I see? Sis? Okay, from the responses, nampaknya macam semua answer ada ni. Nampaknya semua orang vote kepada semua answer, tapi leading ni kepada E. Either C or D is reasonable. Okay, with about 17% of you all jawab E. Okay, interesting. Ini juga yang tak jawab. Okay, so basically kebanyakan you all jawab E lah, which is that's the right answer. Okay, either C or D is reasonable. Why? Why do you guys answer C or D? Anyone want to explain? Yes, that's good. You can either use VKE or NOAC. But why? Why is that needed in this patient? Anybody calculate the chart VAS score? Anyone? What is the chart VAS score for this patient? Female and hypertension. Betul tapi tak betul sangat. Lagi? Anyone? 3. Syafiq, that's right. 3, 4. Yes. Age 65 get 1 score. Female get another score and hypertension. That's right. Very good, Syafiq. So 3. So when your chart VAS score is 3, that means you're at high risk of stroke and therefore you need to give oral anticoagulation therapy. So oral anticoagulation therapy sama ada warfarin ataupun dabigatran lah. It's reasonable. Kalau soalan tu cakap patient is having financial difficulties and is not willing to pay, then warfarin lah would be the option kalau dalam soalan tu cakap macam tu lah. Okay, kalau macam ni, soalan ni tak dicakap apa-apa. So, you can either give warfarin or dabigatran lah. Okay. Kalau soalan tu pula cakap patient ni tak nak, patient is having problems going to the hospital for monitoring because tak ada orang nak bawa dia. Then, your option would be dabigatran because dabigatran dia tak require tak require monitoring parameters. Tadi saya cakap dabigatran ada interaction dengan diltiazem. You need to check, okay? I tak ingat tadi, to be honest. Kalau ada interaction with diltiazem, okay, you can offer other NOAC. Okay, you can check for the interaction lah. Mana NOAC yang tak ada interaction with diltiazem, you can give. Kalau option dia macam tu. Kalau soalan dia ada macam tu lah. Alright, thank you Anis for pointing that out. Okay, that's good. Diltiazem increases blood level and effects of the dabigatran. So perhaps you can use other NOAC. Okay? Alright. That's it. These are my references. Okay. The 2 guidelines. And that's it, guys. Thank you very much for coming into my class. Okay, if you have any questions, you can just post them dekat Google Classroom. Okay, inshallah we'll have our next class Wednesday lah. Our last class with you guys. Alright, thank you so much, all of you. Sorry, you're supposed to have your 551 kan pukul 10. Sorry to take your time. Bye. Have a lovely day.
Thank you, Doctor.
Thank you,
Doktor.
Welcome.
Doctor.
Welcome.